Welcome. I'm Dr. Jeff Borenstein. Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope. Today, on Healthy Minds,
I've enjoyed watching psychiatry as a discipline gain far greater respect than it ever had before. When I was a student, there was no deans who were psychiatrists. Now, it's probably about 15. There are heads of hospitals. And it's not just I want psychiatrists to have big positions. I want people to realize that they are as valuable contributors as anybody else. And I want the hospital and the profession to realize that its number one focus is take care of patients, make them better, understand them, understand their families. And I think it will have a tremendous salutary effect on the entire society.
That's today on Healthy Minds. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, the New York State Psychiatric Association, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Today I speak with longtime leader in psychiatry and healthcare, Dr. Herb Pardes. He's a national figure in psychiatry and academic medicine and serves as the executive vice chairman of the New York Presbyterian Hospital. Dr. Pardes is a former director of the National Institute of Mental Health. He shares his unique perspective about where psychiatry has been, where we are now, and most importantly, what the future will bring. Herb, thank you for joining us today.
My pleasure to be here.
I'd like to start off with you sharing what brought you to psychiatry.
I might mention that having grown up in the Borscht circuit and been accustomed to taking care of people as a busboy, bellhop, waiter since I was 10 years old, I was fascinated by behavior. Well, that interest in behavior was also matched by an experience I started to have in psychiatry, in which I really enjoyed trying to understand what was going on with other people. And I found myself very sharply attentive to what was bothering them, what was on their mind. And if you put all those things together, psychiatry, which at the time I think the same thing today, relates to everything. Science, art, music, politics, seemed like a marvelous field.
It's sort of what makes us people.
You're right. So I went into psychiatry. I was at Kings County. And Kings County at that time had a lovely department with a lot of very good faculty. And I enjoyed watching them, hearing them talk about how to take care of people. So I made the decision I was in psychiatry. When I was in college, I was taken by a psychology professor for a trip to a state hospital. When we went into the state hospital, the thing that just knocked me out was a naked man in an empty room, and the only other thing in the room was feces smeared all over the walls.
Oh, God.
And it was unbelievable. That stuck in my head. And I went on from there. I guess feeling that the people who suffered were people who were often underdogs, who were not treated with the kind of respect and sufficient priority that they should, made me that much more interested. And so in those days, of course, everybody would say, what do you want to be a psychiatrist for? But the more important thing was psychiatric patients were in horrendous situations. At Kings County, where I did the residency, and then ultimately I was the chair of the department there, we hospitalized about 7,000 patients a year. They would come in streams, and in those days they were circulating. They were going from acute hospital like Kings County we would send them to a state hospital, which was right across the street, and told them you better keep them for a while, and they discharged them immediately and right back in. It was interesting, it was exciting. There's a million stories because psychiatric patients are fascinating. You love it if you can make them go better for them. And I was fortunate to have experiences which enabled me to do that. But boy, do you learn about behavior. And so I worked there trying to figure out what are the therapeutic things we can do to help. I was active in teaching, mentoring. I was doing almost everything, and I enjoyed it. And I also wanted to see the profession be better appreciated. Both the patients be higher priority and the doctors be more appreciated and recognized for what they were doing. And by that time, I had left and come to Columbia. I wanted to go to the strongest department I could find in psychiatry, and Columbia was the candidate. So I arrived here in early 1984, and I found that I had this New York State Psychiatric Institute, which is a marvel that New York does, a wonderful research institute.
We're sitting right here at the Institute.
Right, that's right. When I had offers of something which were far more remunerative, and they give you all the perks, but that wasn't what interested me. I wanted to build the great school, the great department. Long and short, I stayed and became dean, but I made one condition. I'll be dean, but I'm going to also be chair of psychiatry. So I was chair and dean for, about 11 years.
Which within the medical school helped further raise the profile of psychiatry.
Absolutely. It also worked for me. I had decisions like this. They came to me one day. They said a fellow named Eric Kandel is working in other parts of the university. Would you consider taking him into the psychiatry department? That took about 1.5 seconds to figure out. Kandel came, Axel came. I started working with the citizen organizations in New York. We built up the clinical programs, the research programs, and now I was doing it for the whole medical school. So I really was interested in having Columbia thrive. And we did pretty well. We got up to about 5th in the country. And I was still active in mental health. I became dean of the medical school. And then subsequently, the hospital people came to me and said, would I head the integrated hospital, Columbia Presbyterian and New York Hospital came together. I said, yes. Interesting, over the course of my life, I've had multiple instances where people have approached me and said, would you do X? And I'm not one for obsessing a long time about things. If I thought it sounded interesting, if I thought it sounded worthwhile, we could help people, that was great. My psychiatric background, whether it's that or me personally, what interested me particularly about the hospital was certainly that it'd be a great hospital. But I'd had my experience over the course of my life as a patient and as the relative of a patient. So when I was 7 years old, I developed a disease called Perthes disease of the hip. And the treatment for that is 10 months in a cast from foot to shoulder, with the only parts of my body not in the cast being the upper part of my torso and my left leg. And that means you went out of school, teaching at home. And I had a few experiences when I was in the hospital in which, at that time, doctors and nurses didn't think that much about children being bothered, upset about anything. So when they took me into the operating room for the first time, they put this ether mask on my face, and I yelled to the doctor, I can't breathe. He said, then shut up. When I was moaning the night before I was going to go home because I was having pain in my hip after they did the procedure on me, the nurse came in and said, do you want to go home tomorrow? I said, yes. He said, then shut your mouth. Those were the kinds of treatments for people, for professionals working with patients. And the days of attention to children, to people, to how they felt weren't there. That became important as a hospital director. Because when they showed me...
You knew the perspective of the patient.
Absolutely. So when they showed me the values that they wanted to promulgate as the lead values of New York Presbyterian Hospital, I said, you've got to have one value in there that's critical: empathy. People have to understand and work and do everything they could to figure out what is on the minds of the patient. I used to use an illustration which I thought was telling. I would say to the medical students, let's say you walked into a patient's room after the woman had had breast surgery. What would you say to her? One person would say, well, don't worry, the treatment's getting better, you're going to be okay. No, don't worry, you're just going to be as beautiful as you were before. And, well, no, your husband will stay with you. I said, I wouldn't say that. What I would say is, how do you feel, and tell me what you're thinking about. Rather than reassuring them about a problem that they didn't have, I'd rather have them tell me what problem they do have and then reassure. And we started working on the hospital here. And I guess the psychological or psychiatric aspect of it was that I wanted as much of an interpersonal flavor to the culture here as possible. And I repeated that everywhere I went. I would talk to groups of staff in the hospital. I would try to explain to people why we should be doing this, not only for patients, but also for families. And the hospital really picked up in terms of a feeling of goodness about what people were doing. And I always believed in a very broad and comprehensive approach to psychiatry. There were some people who would argue with me over the years that what we ought to do is let the social workers and psychologists do all the psychotherapy or psychosocial work, and we should just give pills, and I disagree with that. Because I thought the heartland of psychiatry is the bridging of biology, psychology, sociology. And so we resisted that. The New York Psychoanalytic Institute here is marvelous. The amount of training, the research training, it's just a wonderful enterprise. Through all this time, I tried every way I could to advocate for more mental health research dollars, for better reimbursement for mental health, and for getting rid of the stigma. Mrs. Carter had asked me to do something about stigma, and it was easy for me to kind of join her in that effort. The next 11 years, I was dean of the medical school. I was chair of the department, and we really did extremely well. I got very involved in New York State psychiatric politics and made great friends with all the citizens, and we were really working to make it as good as we could make it. And I kept constantly advocating, whether it was to the state, whether it was to the feds, how are we going to make mental health better? So let's say we zoomed all the way forward and said, so where are we today? First of all, NARSAD, which became the Brain and Behavior Research Foundation, has been a gem. Steve and Connie Lieber are saints. I mean, they are just marvelous. And the way that came about was when I came up here from NIMH, I felt we should explain what we're doing in research in plain English for people.
To the lay public.
Right. And I decided to hold a symposium and invite everybody in, and I'd have people talk just that way to them. Saturday morning, it's raining. I figured, oh my God, nobody's going to come. 700 people came. We met, we talked, we lectured, and Connie and Steve caught me because they came and said, we want to do something in mental health. That something became their ultimately becoming leaders of the Brain and Behavior Research Foundation. And you know this well, that what they did was they made things simply flourish.
They took a small organization and had it blossom
Exactly.
into an extraordinary
Well, it was a comical first meeting when we decided, should we spend the $50,000 we have on grants, or where are we going to get the next $50,000 from? Well, Steve and Connie said they go right past those kinds of worries, and over the years, you know the figures.
Resulted in over $340 million
You got it.
of funding.
Of which Steve, Connie, the Malses, a number of other people put that money together, and it thrived. And now psychiatrists, not only psychiatrists, but neurologists, we've had all kinds of disciplines who get NARSAT awards, feel it's a prize, it's an award, it's a victory. So NARSAT is a strong enterprise. And there were other things which were equally important, like fighting for reimbursement for mental health care. I can't tell you how many different ways we were blocked from trying to get reimbursement to be what it should be so we could take care of people. Well, thank God we've worked and worked and worked for that, and we finally got parity. We still got to monitor it to make sure it happens. But we've got an NIMH which is financially deprived. We've got reimbursement which is very tight. And yet, very recently, there have been a number of developments, some of them terrible, which I believe give mental health a better chance. What are they? It's psychotic young people, usually young, indiscriminately killing people they don't even know. Horrendous. I mean, how could you think of anything more horrible than that? It's veterans coming back from with post-traumatic stress disorder, with drug abuse, with suicide. It's suicides in the country, 41,000, and probably more than that because there's a lot that go unreported.
Even more than the number of homicides.
Right.
Suicides.
It's psychiatric patients flocking in prisons with facilities going down. It's the recognition by the World Health Organization that mental health is the biggest burden, global burden on people's functionality. It's the fact that when you have a psychiatric condition, along with a non-psychiatric condition, you need the most costly care imaginable. All those factors, I believe, have started to make mental health get more room, if you will, on the television screen, a little bit more public attention. There have been major improvements in mental health treatment. If I take as a baseline my poor naked man in the room there, and then look at what's happened now. Yeah, we've deinstitutionalized, which is a mixed blessing. Some people deservedly should be out of the hospital, and they should be worked with in terms of outpatient rehabilitation and therapeutic facilities, and they make it.
They go on and live full, healthy lives.
Exactly. Some don't. So on the one hand, I think that accomplished a certain amount, but on the other hand, I think we overdid it. So I think we should be rethinking the question of available hospital beds for psychiatry patients. If you go into emergency rooms around the country, you'll find the general emergency room flocking with psychiatric patients with nowhere to go. So we need some of that. We need really more programs in which housing is combined with some available clinical help there, which can allow a person who is challenged somewhat to make it. At New York Weill Cornell at Westchester, we have a great program in which Phil Wilner and his team take out patients from psychiatric hospitals who've been there over 5 years and rehabilitate them, get them back into work, get them back into housing, get them back into some kind of life.
With appropriate support, they could do that.
Right, exactly. And it's much better to do that than to keep building jails. All of these current issues, I believe, can be used in the best sense of the word to say we've got to do more about mental health. And I think we can push it to a higher priority. Patrick Kennedy's doing a great job trying to make that happen. I think other people are trying as well. There are some bills in Congress which are designed to help, and I hope that will work. We've got wonderful leadership now. Not easy because these days finances are tight, but they've got to realize that it makes sense for us to do more in mental health. It'll even be economically more sensible because if you focus on the mental health picture, just like I said earlier, all those people coming with all other complaints, it'll come down to the mental health problems. And if we take care of people and put them into a functioning situation, we'll find they'll be better, the quality will be better, and we will need much less in the way of prisons, hospital beds, et cetera. Not that we can do without hospital beds, but we don't have to have as many if we've got good settings in which people can be taken care of. and people who have chronic illnesses who may not be able to make it on the outside so easy, where they can be
Have the
taken
support
care of.
and treatment.
Meanwhile, we've done a lot in terms of developing better treatments, better diagnosis, better research. Some of the things that people in mental health are doing are extraordinary. My hope is that we can see new and additional heroes for mental health, like Congressman Murphy, like other people who are interested in mental health, help us get sufficient resources for research, ensure that parity is carried out, make sure we've got enough people trained as mental health professionals, not only psychiatrists, you need psychiatrists, but you need psychologists, nurses, social workers. There's too many people who need to be taken care of just by psychiatrists. And also, one of the things we're working on is to try to have primary care and mental health care work more closely together. So internists, pediatricians, they're the ones who see a lot of the patients with psychiatric problems. If we can help them, if we can work with them, if we can educate them. One example that we've just worked on recently, instead of waiting when you have a patient coming to the hospital who may come in for a medical condition, a non-psychiatric condition, but also have a psychiatric problem, rather than waiting to first figure that out, then you call the psychiatrist in, we've put the psychiatrist right in the middle of the medical faculty. So if a person comes in who's got a heart condition, is depressed, the psychiatrist is right there.
So that treatment could begin right away, hand in hand,
Right.
with the rest of the
Exactly.
medical team.
What's the result of that? The result of that, people stay shorter time, better quality care. And so if we said we make sure parity happens and that it's implemented, if we make sure that there's reasonable number of people who can take care of patients, if we rebuild some of the facilities that would allow us to hospitalize the people we have to hospitalize, if we can develop living places where people also have some clinical care services right in the same area, we can then drain the prisons of all those people, cut the costs of jail so that the resulting finances will work for the state. It'll be a gain financially, not a loss.
Instead of spending money on not treating people who are in prison, we could spend less money, help more people by treating them out of prison in a safe environment.
Exactly. This is a long story, and as I think about it, I'm glancing over this whole history with bits and pieces. But I would say, if one wanted to say, so what does it all add up to? It adds up to the fact that it's a wonderful profession, that mentally ill people should be helped, understood, nurtured, supported. Research should be vigorous in this regard. I'm glad that the president launched a program on the brain. We've got to have more programs. I think we've got to do more at NIMH to restore work on clinical research. I think they were going down in clinical research. I think that should be reversed. And we should have more trials and more medications. So we've developed, aside from the ones I mentioned, we also had clozapine, lithium, and other people, Herb Meltzer, John Kane, they're creating new medications. So it's a lovely field. I've enjoyed it. And I've enjoyed very much working with all the various people who are in the field, whether that's citizens, families, professionals, other medical people who are professionals. And I've enjoyed watching psychiatry as a discipline gain far greater respect than it ever had before. When I was a student, there was no deans who were psychiatrists. Now, it's probably about 15. They're heads of hospitals. And it's not just I want psychiatrists to have the big positions. I want people to realize that they are as valuable contributors as anybody else. And I want the hospital and the profession to realize that its number one focus is take care of patients, make them better, understand them, understand their families. And I think it will have a tremendous salutary effect on the entire society.
Herb, I want to thank you so much for everything that you've done, for the impact that you've had on our field as a psychiatrist, as a researcher, as a leader, as a humanitarian. And I also want to thank you for joining us here today.
Well, thank you, and I want to not leave this program without thanking you for the great job you're doing here, but also as president of BBRF.
Thank you. I believe that increased public awareness about mental health, steps being taken to improve access to care, and scientific advances in our understanding of the brain will transform the lives of people with mental illness. All people should have the opportunity to lead full, productive, and happy lives. With help, there is hope. Until next time, I'm Dr. Jeff Borenstein. Goodbye. With help, there is hope. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, the New York State Psychiatric Association, and the New York State Office of Mental Health.